Good afternoon, everyone. Welcome to the Penn State College of Medicine COVID-19 and Regional Skilled Nursing Facilities Echo Series. We're delighted to have you join us for this session. My name is Jackie Sable. I'm a member of the Echo team, and I'll be facilitating today's discussion. A few quick announcements before we begin. If you haven't done so, please put your name and email address in the chat box for our record-keeping purposes. We ask that you stay muted unless you're speaking. You can use *6 on your phone or the microphone icon on your Zoom screen to mute and unmute. You can also use the chat for communicating. We encourage the use of webcams as well. So if you have access to one, please feel free to use that. We realize that question and answer time is important to you, and we try to categorize and address as many questions as possible in the session. But if there are unanswered questions afterwards, we'll follow up with any of those open items in an email. Please remember that if we're discussing cases, no personally identifiable information or PHI is allowed. We are recording these sessions and we share all materials and recordings after each session. In the spirit of ECHO's all teach, all learn approach, we're on a first name basis during the sessions. Today's session, it will include a brief lecture on COVID-19 testing by Dr. Kathleen Julian, followed by discussion and question and answers. During the lecture, again, please feel free to put your questions into the chat. We have a team of specialists from Penn State online, and they help field questions or we address them during the discussion. But remember that this is all teach, all learn, so everyone can share both questions and answers. In the interest of time, we're not going to be doing introductions. So I would ask as you interact during the session today, please announce yourself by name. And with that, I'm going to turn things over to Kathleen to start our lecture.
Okay, great. Thank you. Hi, everybody. I'm Kathleen Julian. Can you all hear me okay? Good. Okay. Yes, so I'm an infectious disease physician here at Hershey. And I work with our infection preventionist here on many issues related to COVID. I'm not a laboratorian. But like you, I used a lot of COVID tests and rely on them really, just like many of us do. And we're here to talk about, we really just want an answer. We just want yes or no. Does this person in front of me have COVID or not? But although our tests are excellent, they're imperfect. And I guess this talk is about some of those imperfections and how we work around them. Knowing also, this is also a continuously evolving field. Things are changing, and what I say now, I might change my mind a little down the road in a month or so. So bear with me as we try to navigate this. I'm gonna go ahead and do a share screen, so give me 1 second to get my slides up. Can you all see this? Good, okay. I'm gonna do it make it a little bit larger. Okay, great. And just before we delve into all this, we're gonna have a cartoon. So I got a C+ in math and a negative on COVID. What do we wanna hear? All right. Just talking about testing in general, I just wanna give us a little perspective here. This is a graph from Hopkins about tracking the number of tests per day. So that's in this orange bar. A bar represents the number of tests done in a day in Pennsylvania. And it's amazing what has happened over the course of time. So just focus on the orange. As you see, these in 5,000, 10,000, 15,000 tests being done every day. I mean, I actually remember, I'm sure you do too, in the very beginning of this, back in March when it was just madness, we had to, for every single test, we had to call the state epidemiologist of the Department of Health and ask them, could we please have this test done? And then we had to fill out faxes, and the whole process was rather complex. And now I'm sure the Penn State epidemiologists are delighted they don't have 15,000 phone calls per day to talk about all the 15,000 tests that we're doing at this current point. Just staggering how many we're doing, and yet we're still asking for even more. There's incredible need as this pandemic continues to smolder. Talking about the different type of tests, I want to talk just a little bit to describe how these work. And first of all, talking about the PCR, which you all know well, and just reviewing how it works and some of its limitations. So we have patient is being swabbed, usually at nasopharyngeal posterior pharynx swab is what we've been doing for the most part. And then that sample is put in a solution. Basically, they have to extract the genetic elements from that sample, which has a lot of human genetic elements and also viral elements. They switched over from RNA to DNA. That's just a technicality because the virus is an RNA virus. But the big point, the really key here is that then there's an amplification stage of which is zeroing in on looking for 2 genes that is unique to the SARS-CoV-2 virus, not found on humans, not found on other viruses. And not only are they targeting, really precision targeting, looking for these genes on the virus specific to SARS-CoV-2, but they're amplifying it. So what does that mean? In the process of doing this test, they are taking whatever genetic elements of the virus are there and then making a copy and a copy and a copy of a copy and a copy of a copy. And before you know it, you have a lot of genetic element that then you can detect more readily because you have amplified it and you can see it basically and know that you have found the viral genetic elements and you know this person has COVID. So the PCR is the single most useful test. It is our workhorse. And we would use it all the time except for the fact that it's unable to keep up with the high demand. There's now 800,000 tests per day in the United States. Now sometimes it's approaching 1 million per day, staggering. And just there aren't enough instruments to do this. These require sophisticated instruments in certified labs. And there's not enough testing supplies, basically the ingredients to run the PCR, and they're not cheap. So there are limitations. They're not slow, which is maybe one thing people wonder because you're like waiting days and days to get PCR results back. You're like, but actually it doesn't take very long to run the test itself. It's only a couple of hours to actually, if you have the sample in the machine, get the result out. It's about 2 hours. But the problem is they're so backlogged because we're so overwhelmed by the number of tests being sent in that there's like often can be 5 and 7 day backlog depending on which lab you're looking at. But fundamentally, the test is actually quite fast. What I want to do now is talk about 3 types of tests that we have now. I'm starting with our PCR, the molecular test, and then we'll compare side by side with 2 other tests that we have so you can help us, so we can think about them. So just once again, reiterating, there's a different depiction in the last slide, but we're still talking about the PCR when we're looking for, trying to detect that genetic elements that are in the virus. This is the virus represented here in this red. And we're trying to detect that RNA that is unique to the SARS-CoV-2 virus. And the samples generally are nasal or nasopharyngeal swabs, really nasopharyngeal is what we've really relied on. And once again, just reiterating, it uses an amplification technique to make copies of copies of copies of copies, and then it helps you detect very small amounts of virus. So it's a very sensitive test. Compare that to antibody tests, which are really the second test that came out, but they have a really, really different role. In fact, honestly, don't have too much of a useful role for me and for most of us at this point. But let me just run through really briefly so you have a contrast of what this is. These are antibodies. We're looking for antibodies that the person in front of you, the patient, might make against the SARS-CoV-2 virus. So basically, if a person is exposed to a virus, your immune system reacts by trying to fight it off. And one of the things that makes our antibodies, they're very unique and targeted very precisely to attack and latch on to the SARS-CoV-2 virus. And so the whole idea of this test is try to find those antibodies that are unique to SARS-CoV-2 in your patient by looking in a blood sample and see if you can see, has this person made antibodies against this virus or not? That's really what that's all about. And it's limitations to it, what I'll talk about on the next slide. But basically it takes a while for those to be detected. So it's not as fast. It takes a while for your body to generate enough antibodies. So it really starts only being useful about 2 weeks after the illness onset. Okay, the third test is the most recently developed test, and that is an antigen test. And now we're back to looking for the virus directly itself. You're not looking at immune response of the patient. You're looking for that virus, but you're looking for a virus in a different manner. You're not looking so much for genetic material as we do in the PCR, but we're actually looking for the proteins, and it happens to be on the ones on the outer surface of the virus. This red thing represents that darn SARS-CoV-2 virus, and we're trying to identify these protein spikes that are very unique to this virus. And then once again, it's usually a nasal swab or nasopharyngeal swab. And once again, trying to detect these fragments of this virus. Don't be distracted by the description of antibodies here. That's not the patient's, not your patient's antibodies. These are genetically generated antibodies that are embedded into basically a plate, you could say. And those they're using the fact that antibodies are so good at recognizing very discrete targets, like the proteins on the outside of a SARS-CoV-2 virus. And so the plate comes with antibodies embedded in it already. It's not your patient's antibodies. But basically put the specimen on it and see if those antibodies recognize and find the SARS-CoV-2 virus in your patient's swab. So that's the really quick overview of the three different types that we have. And there are many different companies making each of these. The pros and cons, just to try to boil it down really quick. We've already said the molecular test is really fast. It's 2 hours, but it's more the backlog problem. It's sensitive, but it's expensive. And one of the important point that I'll talk to more later is that it's so sensitive that it can detect fragments of genetic elements from the virus long periods of time after the patient has recovered. And you get these positive tests like weeks later, and you're like, what in the world am I going to do with that? So we'll talk about that more later. But that is a function of this test being so sensitive and being able to pick up just tiny amounts of viral fragments. I said the antibody test is really only useful in certain circumstances. I'm not going to really get into that too much. But the antigen test, whenever you hear, it's very attractive. It's a new thing. It's very fast, 15 minutes. Wow, it's point of care. So that means and many of you all like to ask you about it later, or actually have these instruments in your facilities, might be using them. I'd love to hear how that experience is going. But they're really less sensitive than the PCR because the key difference is they do not have the amplification step. You may remember me saying that the PCR test is unique because it can make copies and copies and copies of itself to help detect the virus. There's no such amplification going on with the antigen tests. It's what you find is what you find. If the sample's diluted or something, you're not going to be able to pick up the virus. So it's not as sensitive as the PCR or the molecular test. So that's a really quick overview of the main 3 types of tests. But let me just go to a few simple scenarios, just try to put this in, understand this. So, all right, I've talked a little bit about the antibody tests, and the question that often comes up is, look, I have a positive SARS-CoV-2 IgG antibody. Well, I didn't even know I was sick, but you know what? Here's my antibody test. It's positive. Am I good? Am I protected? Can I go out in the world? Can I have a party? Do I have to wear a mask anymore? Because maybe I don't get infected again. Bottom line is, it's very clear in the infectious disease guidance in our professional societies, which I listed right here. We cannot rely on these tests to say, oh, I'm good. I don't have to worry about COVID anymore because I'm protected. And that's not true. Because unfortunately, this test cannot assure you that you are protected against reinfection. There's a lot of issues, a lot of decisions that went into concluding this, but even as recently as August, our professional societies again reiterate, do not use this to determine immunity or risk of reinfection. So it's just, you cannot really conclude much from that in terms of, no, you still need to wear your mask, take precautions, because there is a lot unknown and sort of a lot of reasons why they come up with this, but one reason is we don't know enough about reinfection. So if I had SARS-CoV-2 a month ago, I'm probably good for a little while. We don't know how, I probably won't get reinfected right away, but it's not solid, and there's starting to recognize that some limited cases of reinfection have been seem to be diagnosed now. Very, very few amongst all the 26 million or more cases diagnosed so far. In fact, it's only 3 right now. that I'm aware of. But it's very hard to diagnose these. The way these patients were diagnosed was very complicated gene sequencing. They had to sequence the whole genome of a person who appeared to have reinfection, and that's not easily done. So what that means is not easy to detect. I don't want to cause mass panic and say, okay, there's a lot of reinfection going on, but it just points out we just don't know enough about it. And it's stressed again that we can't say if we have a positive antibody test, don't trust that to say you're good and that you're immune, but because in fact, one of the problems is reinfection could still occur. So that's one common question that I get. All right, moving on to another kind of question is about these antigen tests, these new things. They sound great, wow. Why bother with the PCR tests? Because we know that the antigen test, as we said, that's the one on the far right of that last group of slides that I showed you. This is the direct test for the proteins on the outer surface of the virus. We know it's cheap. We know it's point of care. Some of you all have probably direct experience with it, and it's definitely fast. 15 minutes. Wow, that sounds perfect. Well, as we said, there's a trade-off. So the antigen test is probably not as sensitive as the PCR. So what does that mean? You might miss COVID, and a person you may get a test back, antigen test back that says negative, but in fact they may still actually have COVID because the test is not as sensitive as PCR, so you can't really quite trust a negative result. Positive test, we think we can trust that. That definitely is a much stronger case to say, okay, positive antigen test, that person has COVID. But the problem is with, once again, the antigen test, they're citing, you try to get data on like what really is the sensitivity of the test. To get through the FDA, to meet the minimum requirements to get an emergency use authorization to become a commercial antigen test, only had to have 80% sensitivity. To me, that's pretty terrible, because that means, okay, it picks up 80% of cases, great. What about those 20%? That means 1 in 5 is missing potentially. Now, I don't mean to overstate that too, because apparently they have improved some of the antigen tests. That's what some suggestions are. So they'll give us a huge range saying the sensitivity it picks up 84% or maybe up to 98% of cases compared to a PCR. So, but there's a lot of uncertainty. I think it's clear that it's less sensitive. It doesn't have the amplification step. It really, it works best and only in the early stage of illness. And then as the virus starts to fade, it's going to be harder to detect. And we have experience with other antigen tests, like for influenza. And we know for sure that it's, in that case, for influenza, made by the same companies, different virus, but same techniques roughly. The antigen tests are historically less sensitive than PCR. So you might have some false negative results. Looks like the patient has a negative result, but on the antigen test, but not really. It's a misleading negative result. So once again, it works best in the early days of illness because that's when there's a lot of virus in the nasopharynx and it's just easier for the test to pick it up. Okay, outbreak setting. I need answers fast. What about that antigen test? So the FDA has specifically come out with a statement about this. I don't know how literally to take all of this, but it's definitely worth listening to, worth listening to and taking this into account. So here's what FDA says. I have to make something here real quick. If there is a significant outbreak of COVID-19 in a congregate care facility or a high clinical suspicion of infection in an individual resident, a negative point of care test, and they're talking about the antigen, I should have clarified that, should be confirmed with a highly sensitive molecular test. What does that mean? Okay, so here we have an outbreak and you're maybe screening people in the facility, or maybe you have a patient in front of you who looks like they have COVID, you're really suspicious, but the antigen test comes back negative. What they're saying is, be careful, don't trust that negative result. In fact, maybe this is the time you should whip out, go the extra step and possibly do a PCR test after the antigen test. So here's the antigen test. If it comes back negative, maybe you want to be doing a PCR, because the PCR is one of the more sensitive and less false negative results. So that's one caveat the FDA says, again, about the antigen. And it's all about the same thing, just that the antigen tests are not quite as sensitive as your PCR. And also there's concern that it doesn't work very well when you want to screen a bunch of people who are asymptomatic, which is important sometimes in outbreak settings, because once again, the test may not perform as well as a PCR in picking up like pre-symptomatic or smoldering COVID that's just about to make its way onto the scene and manifests itself in the patient. Okay, so right now there's 4 different antigen tests out there, and I'd like to hear from you all, but I understand that the one that first came out was by Quidel, the Sophia SARS antigen test, and then there's the BD Veritor system. All these are detecting those proteins on the outside of the virus, and I understand these are distributed to some nursing home facilities around the United States. And there's 2 more have been recently approved. All these are point of care, meaning don't need a whole complex laboratory instruments. It's a very simple, much smaller instrument that can be done, get an answer 15 minutes or less in some cases. All right. So I told you this talk is a lot about the imperfections of our tests. And once again, I'm going to keep coming back to this issue of false negatives. That's when patient actually has COVID, but the result on your test is, well, negative, which is a false result. The person actually does have COVID. It's misleading. So what are the reasons for that scenario? Well, let me just remind you of, I need to do this again. This graph down here, let me just have you focus on the blue. This is days. This isn't your patient with SARS-CoV-2 or COVID infection. And this is showing the days after start of symptoms. So, and this is day 0, the day start of symptoms, started to get that scratchy sore throat, that headache. And this is showing the amount of virus is going up even before the first symptoms. The virus is replicating, raging around in the nasopharynx primarily. And then with time, after a few days, there's not as much of the virus in the airways, gets harder to detect. I'm not going to really go into the antibodies, like I said, which is shown here in the red, but those come up. The point is that the antibodies come up later. But anyways, what we're trying to detect with our PCR or our antigen tests is this virus in the that is peaking right around the onset of symptoms, but then starts to decline. And so some of the reasons why a false negative test is seen, and we've talked about this many times now, is the test itself is inherently not sensitive. So like the antigen test is not as sensitive as the PCR, as we have said many times. And then there goes the question of sample collection technique. There's some concern, like how exactly should we how long should we put the swab in the back of the nasopharynx? I think most CDC, I think still currently says 15 seconds. So that's like holding it there, but does everybody hold it there that long? And if not, do you miss from virus if you don't hold the sample there long enough? Or what about site? Like I've talked about the nasopharynx, that nasty test where they put it at the back of your nose, to the back of your brain practically, it feels like. But then people are looking at different sites like the nose, just the anterior nose. Now, that's a lot more pleasant, the anterior nose, if you had to pick. But for example, the virologist here at Hershey is says the anterior nasal one, just worried that is not going to be a sensitive enough test, like it's going to miss more cases because there may not be enough virus there to detect. So there's a lot of questions about exactly where to sample. So that is going to be evolving. You can do the sample too early. So if you did really early, did a search, for example, you were screening people in an outbreak setting and you just were screening people who were asymptomatic and they hadn't had a chance to the virus to replicate, it might be too early to detect the virus in the sequence. Or it could be too late. If you down here, it's especially the antigen tests, as I said, they don't work as well later in the illness. So if you try to do a sample here, the antigen test may fail to pick it up and you might get a false negative. All right, I'm a little behind here, but is it okay that I continue them with the slides? Okay. Another scenario, which I know this is a really confusing one, so I'm going to try to walk through this, is people who are, I should say, a person with a PCR test positive for a really long period of time. What to do with those people, and what is going on, and what does it mean? As you know, the discontinuation of isolation, like how long you think a person is infective, like how long could they spread the virus after their illness onset? That's a big question, because we want to know if this person got sick on August 1st, how long do we have to consider them as infectious? Like, is it a week? Is it 10 days? Is it 20 days? How long are they infectious? Or do we have to repeat testing to verify? Well, that has evolved over time. As you know, used to test people after to see if they had cleared the virus. But now that's changed. And let me just try to walk through that data. So just a scenario we had recently, patients diagnosed with COVID-19 pneumonia in June, okay? Hospitalized for that. But thankfully, she fully recovers. But then she has another problem. In August, let me bring our attention to the second line. She is readmitted a few months later with an infection of her leg. And because she needs surgery for this leg infection, she had a routine pre-op test done for SARS-CoV-2. That's part of our protocol. Anybody who needs the surgery, they're going to get an automatic SARS-CoV-2 PCR. And whoa, in this patient, it was positive, even months later. So the question was, is this patient still infectious? You know, they still have a positive PCR. Does that mean they're infectious? Do we have to be careful about this person, put them in precautions? Well, the main answer, the quick answer is, you know, the problem with the PCR is that it can detect viral fragments for a really long time after a person has recovered from COVID. Doesn't occur in everybody, but in some people, you can find virus fragments. I'll remind you, this is not the actual virus that the PCR detects. It's those gene fragments, and we think that the vast majority of the time, those are not infectious. And let me give you a reason why. And we think that actually in most people, the virus is no longer there after about 10 days in a viable infectious form. Why do I say that, and how do I know that? Well, there's yet another test that I didn't talk to you about, and that's viral culture. Viral culture, kind of like you know about bacterial cultures, like for a urine culture. You know, we're trying to cultivate bacteria in the urine sample. Well, you can, if you're a special lab, you can do a viral culture of a sample and look for SARS-CoV-2. This is not a popular test because it's dangerous to the laboratorians, and it's difficult to do, expensive, so we don't do it routinely. But there have been some centers in the world to have investigated this very problem, and they want to know if you culture, you're actually looking for, you know, living virus. Viruses are not quite alive, but a virus that can infect. And so that's what's unique about it. We have data on viral culture. They have found that you can only culture virus after illness onset for up to about 10 days in most people, especially milder illness. It gets a little trickier with very severe disease. It's probably safe after 20 days that you can't find any more viable virus. You culture, you look, but you can't find it. All you get are these little PCR fragments that are just genetic elements, not necessarily live virus. So having said that, that's the reason why that you'll see in the guidance, they'll say person is considered infectious for at least 10 days after illness onset, as long as they've had recovery, their fever's gone away and they've started to improve, because they know that based on other studies, it's really hard to culture live virus after 10 days, except people, two major exceptions. People with very severe illness, like on a ventilator, they have more virus, it lasts longer. And severely immunocompromised people. This is the area we know the least about. People with stem cell transplant. I mean, they have incredibly weakened immune systems, and they can have viable virus, real live virus, that we know from other viruses for a really long period of time, a month maybe, in a small subset. So with the vast majority of people, we can say that they're non-infectious after 10 days, or if we want to be a little more cautious, if they had severe illness, they were on a ventilator, we'd say 20 days. That's based on previous culture data. But the rules are least known about the severely immunocompromised. So if you have a patient with a stem cell transplant, you're gonna feel really uncomfortable about just saying, oh, 20 days, you're good. Those are the people you should consult an infectious disease person or an infection preventionist to talk about how long they really are potentially still having viable virus and potentially infectious. So I think there'll be questions about that. So I'll move on and then we can come back to that. There's an excellent summary at the CDC website discussing all this data. If you want to delve into it, I put on.
Before you move on, I don't know if this is directly related, but
Yeah.
Much earlier, Claire Edelmeyer had posted more of a comment than a question. We are seeing previously positive staff just over 3 months coming up positive, and the DOH is considering these new cases with all of the testing going on weekly, or we may see a lot of this. Do you have anything to comment on that?
So these are people who had tested positive in the past, and then they went negative, and then weekly surveillance tests were negative, and then they come up positive again. Is that what you're saying?
Claire, feel free to unmute your microphone if you need to clarify your point and your questions.
Oh, sure. Sorry about that. You know what? I'm not really sure. We came up, this just recently happened, actually, this week.
Okay.
And I'm not sure, you know, with they may have done a baseline a couple months ago, and now that the requirement is, you know, depending upon where you're located, what county, it's weekly testing for your staff. And it just came up this week that these staff were previously positive, and it's just over that 3 months.
Yeah.
So again, you know, we just need more data, and we need more people doing cultures.
Yeah, I know the cultures are what we love, but they're so difficult to do and dangerous.
Right, and I'm not sure who's doing studies. We are, my partner and I, who I work with, are both members of SHEA. So I've also put that question into SHEA to see if anybody is doing research on this. So, I mean, I just could see just a nightmare brewing, another nightmare brewing.
No, I know.
So
yeah, this is kind of the downside of the PCR being so sensitive. It can pick up these viral fragments so long after illness. Now, so what you're trying to decide is whether this is a new infection, and that's. I know that CDC. I just saw a podcast. It has a whole group that's looking at reinfection, and if you'd like to look at it, I think it's on the IDSA website.
Sure.
Out later, but.
And it may be a new infection. They may be new infections, but it's just really strange that all three of them were previously positive, and now they're positive again.
Yeah, these are people probably not have no symptoms whatsoever.
Asymptomatic.
Yeah, super challenging, I must say, when it gets that far out. I don't have good answers on that. I mean, I think. The best culture data that I know of is this is a slide that I was going to show briefly, is from Netherlands, where they did a lot of viral culture. Like, this is a group of 129 patients. And I'm sorry for all these orange dots and black dots. It's kind of a lot to look at. But basically, it's showing, okay, each dot represents a sample and a patient. And this just shows they're sampling over days after illness onset. So they were sampling a whole bunch. They were sending viral cultures. And the orange represents a viral culture that was negative, and the black represents a viral culture that was positive. And you can see the last time the viral culture could yield virus up to, in this case, 20 days. I think it was the immunocompromised patient. But all these other patients farther out after illness onset were negative. But then what you're bringing up the question is the reinfection, of which is a concern. And I think more to understand about that. And right now, such a small number have been confirmed, but it's so hard to confirm. So you worry we could miss it if it, in fact, it is more common. But yes, it is a complex area. If it's okay with you, I was going to continue here and talk just a little bit about the variation in different PCR tests, just to make you aware. I don't want to drive everyone crazy with all these subtle points, but just to know, there are 161 different companies making PCR tests, which is great because it's like, okay, good, we have a lot of tests now of different companies making it, but it's like, then you want to know all the characteristics and weaknesses and strengths of each one of these. Well, you're not going to know. It's hard to get real good data at this point. But just to give you an example, there was a famous one that came up with this Abbott PCR, which was got a lot of press because, wow, it's a PCR test that's a point of care. Wow, you can do it right, much simpler than the usual PCR. But what was found is, wasn't great, unfortunately. Compared to COBIS, which is a PCR, compared to Expert Set, which is another PCR, more standard, not a point of care, but a regular PCR. The ID Now, which is this point of care one that I'm showing here in the picture, it worked well if there was a lot of virus present in the sample, but it didn't work very well at all if there was low quantities. So sensitivity was about 1/3, which is terrible, actually. So it missed like 2/3 of the cases when the viral counts were low. So just an example of not all PCRs are equal, not to make you crazy, but you just have to have some caution. That's an extreme example, and I think it had a lot to do with being a point of care test, as far as I understand, not being in a laboratorium, but that's got to be part of it. Maybe some shortcuts they had to take. Saliva, spit. Got to talk about that because this is such a thing. You hear, okay, are there easier ways than ramming a probe up somebody's nose to get a sample? Well, it'd be great if you could just spit into a cup. And so there's a lot of companies looking into this. A lot of researchers doing some good work on this. Actually, there's a whole science around saliva. There's it's not just about spit. There's different types of saliva. The type that what they're trying to get is the kind of thin fluid that, if you're thinking about food or lunch or whatever, that's that watery they get underneath the tongue. That's what they want. They don't want the viscous stuff because apparently it's really hard to pipette it up in the lab. So there's these details that our laboratorian friends have to deal with. But nonetheless, here's a New England Journal study that just came out from Yale. They looked at 70 patients with confirmed COVID-19 confirmed by PCR. And they had patients collect saliva samples. And at the same time, they also did a nasopharyngeal swab, the good old back of the nose, back of the brain one. And that was collected by a healthcare provider. And then they looked at and compared, well, how good was the saliva sample compared to the deep nasopharyngeal sample? And so they're somewhat surprising. If you look here, I'm going to move this again. In this graph, it shows you, okay, what were the percentage of tests that detected SARS-CoV-2? And that's up on this axis. The green represents the traditional nasopharyngeal sample, and the blue is saliva. So surprisingly, especially early on, they said that these were similar numbers statistically. It looks a little bit bigger in the saliva sample, like the saliva was a little bit better than the nasopharyngeal sample. But it did vary with time. So here's samples collected 1 to 5 days early on after illness, samples collected a little later, and then samples collected more than 11 days. Now, I could delve into this and ask some questions about this. Why was a PCR positive patient only 70% sensitive 1 to 5 days later after onset? But anyways, we won't go into that. But the bottom line is they were trying to show that saliva looks like a respectable sample after all. Spit might be pretty good. But I think the consensus still is a lot of caution around this because there's some studies showing the opposite. Or at least not as confidently as this study, but it is Yale, it is New England Journal, so it is very encouraging that maybe the saliva is going to hold promise, a whole lot easier to give in general. But there's some issues like if it has blood in it, it can inactivate the PCR. If it's too viscous, like I said, not a good sample, then the lab can't really work with it too well. So in any case, it sounds like it's going to be a hopeful, but not relied upon at this point. and better early in the illness onset, as we heard from all the tests. Okay, so I've thrown a lot at you, but here are the take-homes I wanted to share with you. Once again, we talk a lot. PCR test really is the best. It's really pretty fast, in like a few hours, but that is if you have a lab available to you that can run it, who's not so backlogged. So if you had a choice, like for example at Hershey, our virologist has decided not to pursue the antigen tests because he would rather put all the resources into the PCR because it is a better test in terms of sensitivity. And so knowing that the antigen test is fast, cheaper, can be at bedside, point of care, but it's just the concern about its sensitivity. FDA recommends, especially in high-risk situations like an outbreak, you might consider even taking that. If the antigen gives you a negative result, consider backing that up by doing a PCR, which you're like, oh my gosh, I did 2 tests on a person just to get 1 answer. But maybe at least you didn't test the positives. The positives in general, we're saying we're going to accept the positive from an antigen, but it's the negatives that we don't trust. And so then you might want to follow that up, a negative antigen with a PCR. The serologies or antibody tests, as I said, have a very limited role. They take a while for those antibodies to show up, at least 2 weeks. And usually it takes even 3 to 4 weeks before they really have developed enough antibody. By that's like ancient history, by 3 or 4 weeks after illness onset, it's really late. Saliva tests are promising. And just to say, tremendous amount of progress has been made since when we didn't have anything in March, basically. And now there's a huge number of 161 PCR tests, 4 different antigen tests to choose from. We're going to be hearing more as this all evolves. So with that, I'll try to field some of your questions.
Thank you so much for that, Kathleen. I think you've provided so much information. There is a question that I'm going to see. Daryl, did you want to open your mic and ask that?
I'm not hearing, I'm sorry.
I'm not hearing, so let me try it. Daryl said, how about using, one second, I think we have some feedback here. So Daryl had asked about using Abbott ID Now in conjunction maybe with antigen testing at the skilled nursing facility and nursing homes. Do you have thoughts on that?
Okay, so just make sure I understand the ID Now PCR test, right? And then you're trying to figure out that's role with the antigen test, right? Is that what you're saying?
Daryl, can you clarify, please? I'll try to unmute you.
He said yes on the chat.
Okay. Yeah, I think they have similar limitations as best I can tell. There's very limited, there's so little published on the antigen tests for COVID that I could find. And definitely comparing 2 different assays is going to be hard. But my sense is that they have similar limitations, so I'm not sure how much that complements one another, because they both perform better early in illness when there's more viral load, there's more virus around. And so they also have the same weakness that later they have less sensitivity later. So I really don't know if we can say that they really would complement each other, because they're sort of, in some ways in my mind, somewhat similar strengths and weaknesses, unfortunately.
Dr. Julian, can I chime in?
Yes, please.
First of all, thank you for such a thoughtful and you gave this talk exactly what I wished you would have talked about. So it was just perfect.
Oh, good.
So I have a few questions.
Yeah.
Is there a PCR out of the 120 that you think is the most reliable or the best, or at least you've had the best experience with?
That's a wonderful question. I wish I knew the answer. I don't think there's enough comparisons really to say. I suspect there's a lot of similarities too, except for that ID Now was very different because it was a point of care test. I suspect
Okay.
the reason why it was much weaker.
Okay.
Now I know the Department of Health uses Cepheid. We use Cepheid. we also use several other ones because we can't rely on any one manufacturer because the supplies are not reliable. So that's all I can say. I don't really know how to give you any more guidance other than that.
My other question is that we have the anterior nares collection method versus the what we call the brain swab, right? Does it make a difference? The nasopharyngeal swab that goes deeply in the back of the throat.
So,
Does it make a difference?
So there's the deep nasopharyngeal swab, which is the brain swab, which really goes far back and is uncomfortable. And then you're describing the anterior nase, which is really just in the very front of the nose, not too bad. You know, like our virologist has significant concerns about the anterior nasal not being quite sensitive enough. I mean, what to say? I know that I think the Quidel, is it true the Quidel Sophia 2 is promoting it primarily as an anterior nasal swab, although it's approved for both nasopharyngeal and the deep one and the shallow one. But there's definitely in our virologists, I didn't actually pull that particular literature, but he's really has pretty strong feeling that the anterior nasal swab is probably not as sensitive. I mean, it's good. I'm not saying it's like not going to detect virus, but it's probably compromising a bit. But you have to weigh the unpleasantness of doing the deep one.
Okay, thank you. And then can you have a false positive for the antigen test?
You know, we had the perception that was unlikely to occur. When I was preparing this, I saw there may be more, I think we just can't say much about it yet. I saw some questioning of might be false positives. Did you have a scenario that maybe you were concerned about where you experienced that or had a suspicion that was going on?
I know that Spring Creek is using its Sophia machine for antigen testing. So I was just wondering, we haven't had a scenario.
Okay. I know I just saw in a media report, which is hardly a scientific forum, like not a medical journal, there was some question raised about the BD-MAC, the Veritor, the other common antigen test, but it was not confirmed. I don't want to say too much about it to dash our throat, cast so much doubt everywhere. I think we need to stay tuned for more about that. Does anybody have any more information about that by chance?
I think Dr. Chigbu in the audience wants to know if repeating the antigen test multiple times improve the sensitivity if expected case.
To be honest, I would say getting a deeper sample probably be better than just repeating the same. And for example, if the first sample was an anterior nasal swab, I would personally think it would make more sense to get a deeper sample rather than just repeating the same, let's say, anterior nasal swab. And the reason being is that the more time goes by, the less sensitive the test. And so that's a little bit of a trade-off with any of them, but it's probably more pronounced with the antigen tests. They don't perform as well later into illness when there's less virus. So that's the downside. But it would be good to make sure you have the best sample you can get. Did the swab stay in there for long enough time? Should we do the nasopharyngeal instead of the anterior nares, for example? That's the route I would go instead of just serially repeating necessarily.
And I think another question in the chat from Daryl Jackson is, how about using Abbott ID Now in conjunction with the antigen testing?
Okay, I think that sounds similar to the first question. And Abbott ID Now is a rapid PCR, if I'm understanding correctly.
Right.
But it had similar, that's the one I did see a comparison with more standard PCR tests that are, so Abbott ID Now is a point of care rapid test, whereas it was compared directly with more standard PCRs, and it's definitely less sensitive when there's less virus around, and that problem would be more pronounced later and after illness onset. So once again, that's the same problem with the antigen test, is that later after, when there's less virus, it's harder to detect by the antigen test, and I think it's going to be harder to detect by the ID Now test. So they're I don't know if they got to complement each other. They had the same, to me, they look like they have the same limitations. Not that I've seen head-to-head comparison data, but that's what it looks like to me.
So I think the message I'm getting is when in doubt, use the PCR and not but the other PCRs.
Yeah, if we had easy access to PCRs, I mean, I think that's all we would do. But it's just, the reality is that the PCRs could take longer to get the results back, and that's can be devastating. It'd be better to have a less sensitive test, I think, and if you get it quicker than waiting days and days for a PCR to come back, even though the PCR is a better test. So that timeliness is very valuable with the antigen test. And I think Kydell, the Sophia 2, says they say they've improved the sensitivity of their test. I think by trying to not dilute the virus in their test process, so they have easier time detecting it. So maybe it's going to get better with time.
So I have one question that may be weighing in on some other medical directors is, let's say October and November, we have a full swing of flu in our facilities. Still worried about COVID. Is there a single test we can do? Do you see anything in the future that would test for both quickly?
Okay, I keep coming back to my old friend, the PCR. The PCR is like Hershey's in the process. We hope it's going to actually happen. That they're promising us now that we're hopeful that we'll get a PCR that can detect influenza, RSV, and COVID all in one test. That sounds great. If it gets here, that'll be even more overjoyed because it's so whether they can pull off actually implementing this. Right now, I'm just not aware of an antigen test, by contrast, that is multiplex. Does anybody know? Is there any antigen test out there? Does anybody know that can detect RSV and influenza and COVID, or even just influenza and COVID?
I don't see any responses either.
Okay. The BD, somebody wrote here, okay, the BD Veritor has the ability to run influenza, RSV, and COVID.
RSV and COVID, okay.
Okay. Is it on the same sample, do you think?
Oh, separate.
A separate sample, right. Yeah, Kydell and BD have been making an antigen test for a long time for influenza and RSV. So I could see that they might, maybe they've been making them for a while. We've always shied away from them because those influenza tests, for example, by antigen are less sensitive. But maybe they might even be able to come. I don't know what their future is for that, but.
There was a comment that was posted a bit earlier, and I didn't want anyone to miss it, but Dan mentioned LeadingAge, which is the nonprofit trade association for nursing homes, sent an article that BD Veritor is investigating multiple false positives with their point of care antigen test.
Yeah. Yeah, if anybody has any more information on that, I saw it in a newspaper, which is not where I usually go for medical information, but sometimes the newspapers do get the information ahead of medical journals by a lot. And so if anybody has that information, I would like to know. But yeah, I did hear it from the BD test, not the Kydell. But it's I don't know if it's how far they really investigated that, not to throw everything into doubt.
So Dan, if you have that article or that reference and could send it to echo@psu.edu, we'll make sure that we share it appropriately. Thanks.
Thank you.
Thank you for a very elegant session.
Well, thanks for everybody's attention and your questions, and you all take care, okay?
Thank you.
Thank you, everyone. Please watch for your evaluations, and we'll see you again in 2 weeks.